Hi, everyone. Welcome back to Misconceptions, a podcast about perinatal and reproductive mental health. And I would probably say, especially in light of today's conversation, the contributing factors that are involved in things perinatal and reproductive that are pretty medical. And I think today's conversation is going to bring us back to the very basics, the foundation, the building blocks of what makes us who we are. And today I'm going to just introducing you to Erica Schindewolf, who is a genetic counselor at Children's Hospital of Philadelphia. And she will tell me a little bit more about her professional background. But just to start off with, I feel like almost like in the same way that I do this pretty much every conversation we're having is about, and you are also a friend and also a colleague, and I so appreciate you. And I guess it speaks to this idea of that I love having people in my life who are besides being incredibly knowledgeable, but being so generous of their time and spirit and information. And my interactions with you, Erica, have been consistently again and again, this person who is available and late night texting and can you give me information about this? And I am just so appreciative of having you as a friend and colleague. So welcome to the podcast.
Thank you so much for having me. I'm so excited and so honored to be on your guest list. So thank you. And I think it really speaks to, I think your circle really speaks to just people who are so passionate about what they do and love what they do. And, it's so great to be able to share in that because I know that it's reciprocated when I have an idea or a passion project or need help with a patient. It's like, I know that you're in that lifeline of people. So I'm so appreciative of you.
Oh, that's so great. So let's tell us a little bit about who you are professionally.
So I am a genetic counselor at a children's hospital. I have predominantly been in the fetal medicine space for the last 10 years. And really the patient population that I take care of are coming to see myself and the providers in my clinic because their pregnancies have been diagnosed with something unexpected. They've seen something on an ultrasound or they've gotten a test result that said that something is going a little bit differently than what they anticipated. And most of the time, they're coming to us because their doctors have said, I'm not comfortable handling this. And so we want you to go see some specialists where this is more in their wheelhouse. And so then they come to us and I meet them on their first day, which is kind of filled with crisis, really. And we kind of walk through a little bit about their medical history, their family history, and then, just kind of like guiding through what is the information that they've gleaned so far and what are the possibilities that could exist in the future, and kind of could we do any type of testing that could give us some more information about what's going on with their baby and their fetus, and how do we move through that to feel that we can get as much out of that as possible.
So I know that a lot of the work that you do is reactive, like the reaction to information that comes up unexpectedly. I want us to back this up in our conversation here with many of the people in the Jewish community and especially in the Orthodox community are very familiar with the idea of genetic testing because for many, many years, actually, I think it's been around probably 30 years. No, I would say closer to 40 or 50 years. We have had an organization called Dor Yesharim, which was founded by a couple who themselves had multiple children who had Tay-Sachs disease. And Tay-Sachs is one of those genetic diagnoses that are based on the Ashkenazic Jewish panel. So a number of, we would say that people who typically within the Jewish community tend to marry within the Jewish community. And then we have this almost bottlenecking of genetics where we have these identified illnesses and that can be pretty catastrophic if they present in a fetus, that this couple who had so many children that died from Tay-Sachs started this program. And Dor Yesharim was an opportunity to test before even going out. You would get a number and the boys would get a number and then we would call the main, hotline and say this number to this number. And we would say compatible or not compatible. And what's really interesting about what was set up around Dor Yesharim was this idea of you don't need to know your carrier status. You would just know whether you were compatible or incompatible. And what that really did was incredibly, incredibly successfully, almost completely eliminate the presentation of illness of Tay-Sachs and about 6 other severe illnesses within the Jewish community who were using Dor Yesharim. Things have expanded today. And I know I'm doing a lot of the talking, but I think it's important for people to know why we're having this conversation. People have expanded the Doria-Shum process now is actually 52. I believe I counted them everyone, 52 or 54. And yet there's also this broader diagnosis under J-screen, right? So or J-screen or similar other genetic testing sites. So these are I'm going to say pre-marriage, pre-relationship, pre-creation of child, to look at how we can identify what are some of the things that we could potentially prevent from a development in a baby. So let's start with that, knowing what we know about, let's say, the Doria-Shum process. But let's just set it up from a scientific perspective. What are we looking at from carriers or from those that are non-carriers, perhaps have a dominant trait? Tell me a little bit of the science that we all forgot from high school.
Yes. So thank you for that setup. So what you're talking about is something that we call preconception carrier screening. And that is offered to, anybody who is in that space of being proactive about learning about their health. You don't have to even be thinking about entering into a relationship, nor do you have to be of a specific ethnic or religious background. But what we know is that we're looking, with J-screen and with Doria-Shum, what they're looking is for things that are called autosomal recessive conditions, meaning that every single one of us is walking around with at least 10 or 12 autosomal recessive conditions that we are carriers of. And being a carrier means that you have one copy of a gene that is working properly and one copy of a gene that is not working properly. But your body really just needs one of those copies to be working. So you can have one that doesn't work as well or isn't working at all, and your body is not affected. But where that comes to be important is if you pass on the non-working copy to your future children, and your partner is also a carrier of that same thing and passing on their non-working copy, then you have a baby who's at risk of developing something catastrophic. And so because our bodies don't register that, if you're a carrier of something, like I am a carrier of something called ectodermal bullosis, which is a skin condition that the type that I'm a carrier for is actually fatal in utero. So I don't show any symptoms of that. There's no way I would know that. There's nothing in my family that would tell me that I have that. It's only from that testing that we looked and we spell checked those genes to say, okay, she has one working copy and one copy that's not working. So when I went to go get married, then I had to, think about, was I going to do anything with that information? And did I want to have my partner screen for that to know if our kids would be at risk? And so that's why that testing can be so important, because also that condition in particular, and most conditions that are on carrier screening, don't have ultrasound findings. So when we think about things like Tay-Sachs, like there's not really anything that we see prenatally. And so you could be going through your pregnancy thinking, everything looks great. We're getting all of this good information. And then you have a baby that's so sick. And, then you're trying to figure things out afterwards, which is just a situation that many families unfortunately are in, but certainly never what we want for families when they're, just trying to deal with all of the transition that happens after having a baby. So that carrier screening is really meant to kind of give us that information, empower us to think about, could we think about things differently, either in choosing a mate or thinking about how we move forward with conception, or do we do IVF, or do we screen differently or test with pregnancies if we're going to conceive naturally? Kind of gives us those options to have a little bit more control.
So now talk to me about like when you have for, I remember when I had my children, there was very minimal genetics testing that was done while we were already pregnant. And then things seem to have changed where there's some level of screening that's actually done at week 11 or 12. Can you talk to me a little bit about what we're screening for at those weeks?
So the first trimester screening that can be done is done kind of in two different buckets. The first is the ultrasound. A lot of people are having ultrasounds in the first trimester, first to establish viability, and then second around that 11 or 12 week to do something called the nuchal translucency scan. And that scan in particular is very important for genetics, because the nuchal translucency scan looks at the back of the baby's neck and it's looking for excess fluid. It's kind of measuring that. And a lot of times you have to go to an MFM office to have that done. If there's
hold on, maternal fetal medicine. So somebody who's considered, we used to call them high risk OBs. And these are people who are highly, have an additional fellowship beyond their OBGYN residency.
Yes. So to do that ultrasound in particular, you have to have a specific type of training. And if there's an increase in that measurement, then that gives a kind of red flag to say that this fetus could be at risk for a structural anomaly or a genetic condition. And then the blood test that is often done in the first trimester gets a lot of kind of media attention right now and a lot of kind of societal attention because that is the blood test, which a lot of people say, oh, I want to know the sex of the baby, the biological sex. And so I want to do this blood test early on because that's the way you can find that out. That blood test is looking at something called placental DNA. So it's the DNA that is derived from the placenta, which the placenta is kind of the organ that mom creates to help give nutrients to the baby. That DNA is, in theory, the same DNA as the baby, and that sheds off into mom's bloodstream. So we can actually look at mom's bloodstream, differentiate between mom's DNA and the baby's DNA, and what it can tell us, what it typically tells us, is about conditions like Down syndrome, trisomy 13, and trisomy 18. So those are kind of common chromosomal conditions that have a risk in any single pregnancy and are easy to look at under a microscope. And we look at those three conditions, and then it can also tell us about sex chromosomes, X and Y chromosomes, which typically tell us a biological sex of a fetus.
So we are using the word genetics, but really I understand it to be like two different kind of things, right? The things of the genetics of what I inherit and give to biologically to the child that I'm carrying versus the genetics of testing. Could we differentiate between the two? Talk to me about how we differentiate.
So I think that is such an important point because I think a lot of people use inherited and genetics interchangeably. And so when we talk about genetics, we're really talking about, just as you introduced, the building blocks of that individual person or organism. Genetics is truly the instruction manual in which your individual body is built. Now, that instruction manual comes from a shared biology of your biological parents, but there's information that your biological parents give you, so the genes that they give you, and then there's kind of this random reorganization of all that material that happens to make you an individual. Because if there was just 50% of mom, 50% of dad, and then they came together, we'd all kind of be clones of each other. We need some random variation to become individual people who don't look exactly the same or act exactly the same as our siblings, but closely. And so genetics it really is about the family, but more is surrounding or discussing that individual person, whereas inherited means, is this coming from mom or dad or one side of the family or another side of the family? The examples that are easy to kind of give there are like Down syndrome, for example, trisomy 21 is a genetic condition because it is a condition involving an extra chromosome, which is a whole extra set of biological information that your body is then having to process and has changes because it's processing that. But typically, Down syndrome, even though it is a genetic condition, is not inherited. It usually is a new change in that egg and sperm coming together that is just random and won't happen again in a family. So it's not uncommon that I hear from families like, oh, it's Down syndrome, but it's not genetic. And what they're really meaning is like, oh, it's a genetic condition, but it's not inherited. It doesn't run in my family. And we were told it shouldn't happen again. And most of the time that's true.
And so what we're saying is that we can have presentation of illness from two people who are non-carriers of anything to quote unquote healthy enough genetic lines that come together and something becomes disrupted or goes wrong in the development of that fetus. So when somebody does, now here's where it gets a little bit wonky in the wording, right? So somebody says, well, I did pre-genetic implantation testing, right? I did PGD testing or PGD-A test, whatever the terminology is of today. When I did my pre-genetic implantation testing for IVF, these were chromosomally normal. So therefore, I've minimized any risk or limited any risk that I might have of having a baby with fill in the blank, right? So can you assign the proper terminology for that testing versus when you say, let's say for that testing?
Mm-hmm. Yeah. So the farther we go in this, the kind of like more difficult it gets, right?
Right. Exactly.
it's so complex and it's so amazing that like we are able to even talk about this. But if any family feels confused in this process, it's because it is just that complicated. So, what a family is talking about when they say, hey, I have screened my embryos for chromosomal conditions, and they were reported back as chromosomally normal. What that means is that someone looked and said, is all of the genetic material here that the baby needs? Is there anything extra or anything missing? And so I always use kind of the analogy of thinking about a library, which none of us really go to anymore, but I hope we do. And in this population, hopefully people do. And we are, looking at all the books on our shelves and we are saying, okay, I know there are supposed to be this many books and I'm seeing them all. So they're there. That's good. I'm not seeing anything that's extra. I'm not seeing anything that's missing. And I'm seeing things like where they're supposed to be. Nothing seems out of place. That's what that testing is telling you. What it's not telling you is, in the red book, in the third red book, is that supposed to be written in English? Is that supposed to be written in Chinese? Is that supposed to be written in Spanish? It's not telling you what information is inside that book and if your body can actually process that.
Mhm.
And so there's a whole different type of testing called single gene testing that is actually about opening all of those books and reading them and making sure that your body can interpret that information. And that you can't really do off of pre-genetic implantation or off of just like doing that test because you want to. You have to kind of do that testing because you have a certain indication, like a genetic condition in your family, or a very specific thing that you're looking for, or a structural anomaly that you want to look at the genes that are contributing to that anomaly. And so it's really hard for families, understandably, when they say, like, but we screened for everything. And then you're presenting them with this whole other world that they haven't looked at because they haven't had to. And it's, I think it can be really
Right.
overwhelming.
And then to layer one last thing onto there before we continue, but because I think that these are the nuances of this knowledge that I think is so important for people to understand. So things can also happen in development. Or, for
Mm-hmm.
example, spina bifida, right? Let's use that as
Yes.
a simple explanation where that baby would be chromosomally normal, correct?
Mm-hmm.
Okay. And yet the development of that fetus is definitely not aligned with what we would consider normal development. Does that have a genetic component to it or chromosomal component to it? Or it really doesn't, and it's just about how the genes express themselves as they began to divide and multiply, or multiply and
Yeah.
divide.
So what that's called is multifactorial inheritance or multifactorial development. And essentially what that means is that we would expect for developmental changes like spina bifida that the majority of the time there is not going to be a genetic component or a chromosomal component that says this caused this to happen. It's more this kind of really multifactorial piece where there is a maybe womb environment that we have no control over, or extrinsic factor we have no control over, or other intrinsic factors that are kind of all working together to create this developmental change that is a deviation from the typical process. And
Okay.
most of the time for those multifactorial conditions, there's kind of no way to know how all of those things came together or if they'll come together again in that way.
Right, which is really distressing, obviously, to
Yeah.
parents, because like I think some parents said, but I did all my pre-genetic testing, I did my pre-implantation, genetic screening, I did all the screening, and that how did we end up here? And I think that
Right.
that's part of the sometimes a little bit of a gap in the knowledge around what is talked about when it comes to what is really within our control with testing versus not testing. So moving into, we have somebody who is in a regular, let's say, quote unquote, normal, healthy pregnancy, when we are, kind of just giving some consideration to some of the to the genetic situations. Let's say we know that there's something genetically wrong, or they're both carriers. What are the, let's say, okay, let's take it back, pre-pregnancy. What are their options? Like, what is the options that are available for someone who knows that they are indeed carriers of cystic fibrosis or Tay-Sachs or something like you described about your own genetic history?
If you know that you have two partners that are carriers for the same thing, and that's like a big important asterisk, right? Because if I'm a carrier of something and my partner is a carrier of something else, it doesn't matter. We
Right.
have to be carriers for the same thing in order for that risk to exist for our potential children. And so if you are carriers of the same thing, we'll use Tay-Sachs as an example, then we have some options to think about. The first could be that we decide that we are going to try to conceive spontaneously without the help of medication, natural conception. And so if we are able to get pregnant on our own, which your carrier status should not impact by any means, but you learn that you're pregnant, then the earliest you can test for that specific genetic condition that you are both carriers for is around 11 to 13 weeks with something called a CVS. And a CVS stands for chorionic villus sampling. That is a sample of the placenta. And what they look at is specifically the genetic changes in the gene that you are both carriers for to see if the baby is either a carrier, like the parents, or affected. And so you could know at that time, which really the earliest results would come back would be about 15 weeks. So right after the end of the first trimester, you would know if the baby is affected or not affected with that condition.
And that would be done via ultrasound, via of amnio guided, ultrasound guided amniocentesis, correct? In order to get out the placental tissue.
Ultrasound guided chorionic villus sampling, which is kind of like the first trimester equivalent to the amniocentesis. Same type of procedure. So an amniocentesis is really describing a ultrasound guided procedure in which they are taking a sample of the amniotic fluid via needle. Instead of taking the amniotic fluid, they're taking a sample of the placenta. So it's
Okay,
similar,
good.
similar.
Okay, so understanding that I want to use those terminology that you said, they are carriers versus they are affected. Okay, so carrier is no different than the parent, carrier status. They will pass that on to their children in the future as potentially as carriers. Affected means that they have the expression of the illness themselves. And
Correct.
then when a parent finds out that that is indeed what we're looking at, carriers, you take a breath, a sigh of relief. Affected, what are parents' options?
Affected, then you kind of decide what are we going to do? Are we going to continue with this pregnancy, anticipating that you have a different team, when the baby is born, and we have the right doctors in place to do any type of treatment that could be possible? Do we choose to terminate the pregnancy? It's kind of that juncture where we say, okay, where are we going next? Are we using this information to guide our pregnancy management to continue or to not? I will say that we are at a space in medicine where we are actually starting to really have treatments for a lot of these conditions that used to be fatal, and that were thought to be life limiting. And so the options, even for things like cystic fibrosis, which we know is not a fatal condition, but certainly has quality of life differences for those who are affected. Now there are medications that even a pregnant mother can sometimes take, depending on a few different factors, to minimize the progression of the condition while they're pregnant. And so we're at a really exciting time. It doesn't certainly take away all of the stress that goes along with even thinking about all of these things. But you're at that point where you learn, okay, my fetus is affected. Is there any treatment possible? What am I going to do with this information on how do I move forward?
And I think what's really interesting about that is that when I was myself pregnant many years ago, we were really told, like I had this conversation with my OB and I said, well, if we have this testing and I'm told that there's a problem, the only option would be termination of pregnancy. Like it was clear that there was no intervention available at that time. And I was not a carrier of any known, or I didn't have any known carrier issues, right? Like, but I think that, and at that point I said, no, I don't want to know because what's the point? I'm not going to terminate the pregnancy. Today, I think what you're saying to me is that besides the fact that knowledge really also will help support the pregnancy toward a healthier conclusion for both mom and baby, and potentially for really being prepared postpartum medically, that there really might be some things that have a medical intervention available to help guide this pregnancy into a healthier outcome, which is really, really neat, really exciting.
Yes. And I think, speaking of misconceptions, I think that's number one of when people are asked about genetic testing, they say, well, am I getting this so that you can tell me that we need to terminate, or are you offering this because we're somehow implying that this is an option that we may have to think about? And I think as genetics providers, we are really thinking about offering genetic testing as a way of being able to empower your decisions about treatment options or just preparing yourself for what could
Right.
be ahead. Because we certainly know that there's so much power in just having the ability to think through what the plan will be, even in getting yourself in a psychosocial space to be able to just like receive the information in a different way when you have time to process it.
And so I think that also gives that up the question that comes to like, okay, so now we find out that we know that we are both carriers. One option that we just talked about was the idea of getting pregnant, making plans, and
Mm.
knowing that one of that options would be to terminate pregnancy. And I remember, many years ago meeting someone who knew that they were Tay-Sachs carrier, and this is what they did, and they tested at 11 weeks, and if they came back that the baby was affected, they were terminating pregnancies. I've worked with other couples who were doing the same thing with things like Fragile X syndrome, and some that were it was a heavy family presentation. Fragile X, I'm going to put it into its own category because it's such a fascinating
Yeah.
it has some unique genetic components to it. But in terms of the alternative option, let's talk about IVF, because really that's the primary choice that would be ideal, but also has some limitations. What's your perspective on that?
Yeah, so IVF is kind of the other road that families can go now once they find out that they are both carriers or have an increased risk of a genetic condition in their children. And so you can do IVF for the sole purpose of selecting against genetic conditions. And so when you do IVF in that process, you are creating embryos. You are then testing 5-day blastocysts. So when the embryos are 5 cells big, or about 10 cells big, they do a biopsy of 2 or so of those cells, and then they test them for either a specific genetic condition that you're carriers for, or oftentimes additionally, they are looking at the chromosomes to see is there anything extra or missing. And so when we do that testing, then you kind of get this report that comes back and says, okay, of all of the embryos that you have, here are the embryos who are carriers, here are the embryos who are affected, here are the embryos who are not carriers and not affected. And then you as the couple have the option of figuring out what and how you're going to implant those embryos. And most people are implanting embryos that are either carriers or unaffected carriers, or sorry, unaffected and not.
Unaffected embryos, right? One of the things that I think is interesting, I remember hearing from a geneticist that actually she was an embryologist, was she corrected me, perhaps you know it differently, but that the idea that we're actually taking cells from the placenta of those developing embryos versus actually like removing a cell from the developing embryo because they need all of those cells. Do you know it differently, or are you teaching it differently?
So now we're getting like even more granular.
Yeah, let's get into the weeds. Come on, let's get into the weeds.
Basically, when they're doing this testing, what they're doing is they're testing something called the outer cell mass. And so if you were able to look at these embryos under a microscope, which a lot of people get, these beautiful pictures of their embryos to take home with them, you'll see there's like this outer cell mass that looks like a big circle, and then inside there's something called an inner cell mass. What they are testing when they're doing PGTA and PGTM, which are PGTM is for the carrier conditions, PGTA is for the chromosomes, is they're just taking 2 cells from that outer cell mass. And so that outer cell mass will eventually go on to become the placenta. The inner cell mass will go on to become the fetus. So they really, yes, are not touching the fetus or what will become the fetus, but
Right.
in more simpler terms,
Who said we were talking simple? I told you we were getting complicated.
we are going really complicated.
You know what? We got to go complicated because the masses don't learn these things, right? The
It's so
laypersons, I
true.
never learned that. I don't have a master's in genetics, but I definitely need to understand these things as a therapist who works within this realm and within this community. I must know the differentiation between the two so that I'm not caught off guard when I'm like, wait, how did that happen? Right? That doesn't make sense. Okay. So to me, like, I think this is fabulous, and probably some people's heads are like exploding open over all the details, but I think it's a good detail that we're talking about. I think it's fabulous. In your work as a genetic counselor, maybe we could just spend a couple of minutes around. I'm curious to know your opinion about the mass testing, the J screen testing, versus the more limited testing, and not exposing our young couple to the heaviness of the emotional weight of holding you're a carrier of this or not, or you have you have this problem in your genetics. And I think that was a part of a lot of that has to do with stigma. I believe a lot of it has to do with trying to eliminate stigma or push the stigma to the side. But in some ways, I think sometimes when we talk about it like that, we're actually enhancing the stigma. We're saying, oh, like we can't talk about the genetics of a person because it's going to be a problem for marrying them off in the future. So I'm
Right.
curious to know your opinion about genetic screening when it's wide, it's like a wide brushstroke versus more limited.
I mean, I think ethically it's so tricky because we're talking about autonomy of a person, and they should have the autonomy to be able to make the decision to know the information about themselves. But it's also, I think it also goes to really needing appropriate pre-test counseling. And I will say that the majority of people that are being offered carrier screening, whether it's limited or more kind of broad-based hundreds of conditions, are really not getting appropriate carrier preconception screening, where people are sitting down and talking to them about like what this information may mean to them, and what they may do with it. A lot of times these conversations are happening in a doctor's office where someone's saying, do you want carrier screening? Yes or no? Or like,
Check,
what's your
right,
ethnic background? Like, check the box. And then later they're getting these calls saying like, you're a carrier of this. And they're like, I don't even know what that means. Like, I don't even know what that word means. So I would say my opinion is that everyone should be offered it with proper guidance of thinking about, if you learned this information about yourself and learned this information about your partner, how might you go about changing things for yourself? Are you using this to become empowered? Are you using this to think about, would you pursue IVF? Because having those conversations early on, I think, is heavy, but I think is a totally different space when you can think about it in an abstract kind of philosophical, what would we do, rather than in the moment of, oh man, now we have to make a decision.
right.
Or potentially worse so when you do have a child who's affected with something and you're saying like, I wish we would have known this, or I wish we could have done something differently, or prepared ourselves differently. So I think that's a piece of it, that I think is so important. And I just think that, the other piece with stigma is that, I think if every single person was offered this testing, and we really did realize that 60 to 70% of us are going to have something come back as abnormal on these screens. That's a
Sure.
lot of people that are having, things to think about. But certainly, it makes it more normalized to be like, yeah, most of us are carriers of at least a few things that we're already testing for. And so, we can feel more normal in having those conversations of being like, oh, I'm a carrier for this. What are you a carrier of? Because we
Right,
know
right,
that's, it's just
right.
variation, and it's normal variation.
I think the other piece I think I just have to introduce here is recognizing that there's the practicals of getting the information and having the information and the potential empowerment of having that information. There's also the emotional component of having this information and what do I do with this information? So emotional meaning even things such as IVF is expensive. So
Mhm.
you have to, if you have this information, you know that the main likelihood or the best outcome would be to do IVF pre-implantation, pre-transfer testing, and then you end up with a $50,000 bill, right? No, are we prepared for that? And if we're marrying very young, are we having conversations around not only the cost of IVF, but also the fact that it's not 100% guaranteed either. So it's not like I'm guaranteed IVF will guarantee me a pregnancy and a baby. And so I think just recognizing like these are broad conversations around expectations that I don't know how many of us are like so ready to have these conversations with our 20-year-old daughters or our 22-year-old sons, right? And so it's not, I put this out there as a question mark versus a solution or an answer, or like we should be thinking about this,
Absolutely.
but just putting it out there. We know there are organizations that do help with, financially with things like IVF, but I think that we have to be really alert to the emotional complications of going through IVF, of going through infertility treatment, especially because they're like, my body actually works just fine. Like I could probably conceive naturally, barring any other common kind of complications. And yet here I am in an IVF world. And I think a lot of parents who are very involved in these kinds of decision making are like, why would we set our kid up for that kind of difficulty? Like why even put them in that space to begin with? So just kind of putting out some of the cultural, religious and Jewish law components of it, I think is a fascinating kind of add on to that conversation. Um, Okay, so in the last few minutes that we have together, because then you and I, we could talk forever, but what else would you like to make sure that we mention when talking about genetics and genetic screening in terms of pregnancy and preconception planning? Is there anything I didn't hit on?
Mm, I think the only two things I would continue to think about are that the genetic screening and genetic consultation itself is not something that comes with a hefty price tag. And I think that that still is a misnomer across the board when people think about genetic testing, is that people think genetic testing is something that feels so sci-fi and, is going to be this crazy expensive bill. And really, most insurance companies are covering both the consultation and the testing. And so I think just entering with that space can be important. And then I think just like finding the right therapist or the right doctor that you like, I think finding the right genetic counselor and or geneticist is about fit. And I think a lot of people also feel like they can't kind of get second opinions or explore other options because sometimes there's only one person in a hospital system, but we're moving into a space where there really is so many more private practice or consulting or online options for genetics providers. And I really think that kind of to really fit the needs of the person in front of you is so important, and something that isn't talked about as much. So I would say, especially in the preconception space, those are two things that I think we could do a better job kind of sharing out into the world of saying you really need to find the person for you. And you really should also know going into this that people are going to advocate and make sure that you're not spending tons of money to get the answers that you're hoping for.
And where do people access a genetic counselor? Where would they actually find you or someone like you?
So the National Society of Genetic Counselors, which is nsgc.org, has a whole page of find a genetic counselor. And you can type in your zip code and it will pull up genetic counselors in your area. That's probably the best and most up-to-date place to find a counselor. And then if you are attached to an OB office or an REI office, if you are already pursuing fertility for some reason, you could also ask if they have genetic counselors that they work with, and say that you want to kind of talk through preconception screening or genetic screening in general to see kind of what would be the best for you.
I think that's great. Okay, ready? Top three misconceptions that you want people to know about genetics and chromosomes and genetic counseling. You already said one really good one, right?
Mhm.
That idea of like a misconception that, go ahead, I'll let you say it.
Yes, a misconception that genetic testing does not equal termination of pregnancy, or genetic testing does not mean something negative too, right? Like genetic testing just means getting another data point for you to be able to take the best care of yourself or the best care of your baby. And really, like, that is how we should be thinking about this. I also think a misnomer is that while genetic testing is always optional, we kind of always approach this with like, you can choose if you want to do this or not. I kind of always think about it as like, if your doctor said to you, you can choose if you want to have an MRI or not, it's like a very interesting conversation and or space to think about. So while it's optional, I often like always want patients to be able to advocate for themselves and fight back and say like, well, why is it optional and what might it add to my care? And I think a question that we get a lot is, why is this testing important? Like, what is it going to mean for me? If you can't do a treatment or you can't magically fix this, like, why am I going to do it? And I think realizing that learning information to better prepare yourself for the steps that are ahead and making sure that maybe you're delivering at a different hospital or you're having different surgeons there, or maybe there are just specialists that are right around the corner from you that you didn't even know you needed. Knowing and being able to plan for that takes away a lot of stress and also really does improve outcomes for moms and babies. And so I think added information is added power, and better outcomes for families. And I think that's so important.
Fabulous, fabulous. Erica, thank you, thank you, thank you. I have already in mind what we're going to talk about next time, but for today, thank you for being a part of this conversation and for sharing your knowledge and wisdom to the audience.
Thank you so much. Thank you for having me.